affects some aspect of their life. And a lot of times BPH will also affect their partners. A lot of times patients will be getting up and running back and forth to the bathroom, and it disturbs sleep and makes us cranky and all sorts of other potential quality of life issues. So who can get BPH? Usually it can start in the late 40s to starting in the 50s. By age 60, it affects about half of men. And to some degree, it's a disease of aging. By 85, almost everybody has some issue from BPH. So how do we diagnose an enlarged prostate? A lot of it's sort of the history of the patient, physical exam, the digital rectal exam, and then some urinary flow testing can also be helpful in the diagnosis. We use a couple of validated questionnaires that are also very helpful, and sometimes even we'll, at some point in the process, do a scope of the prostate and the bladder to get some more information. So what are the treatment options? Treatment options go from behavioral modifications to first-line therapies to then surgical procedures. And they obviously are increasing on the level of invasiveness as we go to the right. So alternative medicines, there's a lot of advertising for various prostate pills. There's been some studies small studies that saw Palmetto may have a little bit of an improvement on urination, but then when they did the big randomized trial, really didn't see very much benefit. I do have patients who feel like they have some benefit, and so great, but really there's no pill that's going to really completely relieve these symptoms, regardless of how good of advertising is done. So watchful waiting. Watchful waiting is essentially keeping an eye on things, doing yearly exams, avoiding surgery or drugs. It can involve lifestyle modifications like changing diet, potentially supplements, avoiding fluids in the evening, changing around medications, and potentially exercise. And for some people, this is really helpful. There are individuals with especially nighttime only urination who, if we potentially change medications around, potentially treat sleep apnea, and modify fluid intake in the evening, we can really have some good results and really improved quality of life. So for some individuals, this is a good option. The downside is that more and more we're learning that untreated BPH tends to be a progressive disease, where the longer it's untreated, the worse the symptoms are. And oftentimes, if we wait too long, it may be more difficult or even impossible to reverse a lot of the effects on the bladder. So for medications, there are two main classes. The first here are alpha blockers. What alpha blockers do are relax the smooth muscle of the bladder and the prostate and hopefully allow the urine to flow more freely. The benefit is, obviously, this is still non-invasive. The downside is that the alpha blockers, like any medication, can have some side effects. The most typical one that everybody's probably heard of is Tamsulosin or Flomax. And that one, even so, can cause some dizziness, lightheadedness, sometimes nasal congestion, and will oftentimes cause dry ejaculation. A lot of people take this medication and feel like they do well with it. The other downsides to it, one, the Tamsulosin or Flomax, it really helps with symptoms sometimes, but it doesn't necessarily change the physiology of voiding and doesn't necessarily protect the bladder from future damage. There have also been a couple big studies lately that are concerning about possible other downsides to taking this medication. There's even possible association with things like dementia and heart disease, although those are more associative studies and haven't really definitively proven any problems there. But still, some downsides potentially to long-term use of these medications. The other category of medications are the 5-alpha reductase inhibitors. So these are medications that work by preventing the conversion of testosterone to DHT, and they can actually shrink the size of the prostate uh, by a factor of about half. It does take about 3 to 6 months to really work. The advantages, again, it's non-invasive. The other advantage is that studies have shown that the 5-alpha reductase inhibitors, those are the medications like finasteride or dutasteride, they do decrease hospitalizations for urinary retention, and they can actually prevent the need for surgery potentially. The downsides are that, again, this medication does have some side effects. So it can cause some issues with erections, sex drive, fatigue, and even breast tissue development rarely. Also on the slide here is that it can, or it does lower the PSA level. Not really such a big deal as long as we know that you're taking it. We'll just correct for that, but certainly something to keep in mind. So moving on to the procedural options. The first is water vapor therapy, or the otherwise known as the Rezum procedure. So this is a non-surgical in-office therapy that helps to reduce the size of the prostate and the obstruction from the prostate by using a natural water vapor or steam to treat that tissue. Some advantages are that it does preserve sexual function and generally get back to regular activities in a few days' time. So there's no general anesthesia, no permanent implants, and very impressively, the retreatment rate has been quite low. So less than 5% over 4, now about 5 years. So a low retreatment rate for a minimally invasive treatment. Downsides, oftentimes do need a catheter for at least a few days to a week, tend to have some irritation with urination, frequency, urgency, discomfort peeing that usually takes a couple weeks to a month to really resolve. And the last thing here, in about 1 in 20 people, it may decrease the ejaculatory volume, although usually that's not by a great deal. The next treatment here, the prostatic urethral lift, otherwise known as the UroLift procedure, is another non-surgical outpatient procedure. It uses prostate lifts, implants or clips to remove the prostate tissue from the channel so it is no longer blocking the urethra. Potential advantages are that it doesn't involve destruction of prostate tissue. It doesn't affect sexual function. There's no general anesthesia. Potential negatives, it is a permanent implant, and there's a little higher surgical retreatment rate, about 12 or 13% over a 5-year period. Afterwards, again, can expect some frequency, urgency, discomfort, urinating. About 1 in 5 people does need a catheter after this procedure, although most people do not. And there can be some discomfort in the pelvis after the procedure. Usually goes away after a few weeks, but does take a little while to completely normalize in some people. The transurethral microwave therapy is an older treatment. We won't talk too much about that one. That not really used by most people as much anymore. Laser therapy or photovaporization of the prostate uses a laser to vaporize prostate tissue. This is a surgical procedure, very effective for relieving the symptoms of BPH and relieving obstruction, but a procedure that requires general anesthesia. For the right patient, a great option, but is certainly more invasive. Similarly, the transurethral resection of prostate, or the TURP, is the older gold standard for prostate BPH treatment. Again, it's a hospital-based procedure that generally requires at least an overnight hospitalization. And again, it's more invasive and does have more potential complications associated with it. Finally, removing the entire BPH tissue is called a simple prostatectomy. That can be done through an open or a robotic approach. This is obviously a more invasive procedure. It's generally reserved for patients with a very large prostate. Is very effective when necessary, but for most people, there are more minimally invasive options. So insurance coverage, generally all of the options discussed are covered under the majority of insurance plans and Medicare as well. So the summary, we talked about what the prostate is and generally what it does. We talked about what can go wrong with the prostate. And then we talked about these treatment options, being watchful waiting, really just kind of observing and not really treating with any medications, possibly using some plant-based therapies. There were a couple questions previously about some of these, and really the only one with any significant data is the saw palmetto, although there are a couple others that that we could discuss if people have more questions. First line therapies, that's mostly either the medications like the tamsulosin or Flomax or the medication finasteride. There was a question before the webinar about the potential benefits and risks of using the finasteride 5 milligrams once daily. And I think for the right person, it's a great option. It's a way in many people to avoid needing a procedure done, and that certainly is great to be able to avoid if possible. It does decrease the size of the prostate, so in some cases it's treating more the problem than the tamsulosin Flomax medications. The downsides are that it really does take at least 6 months to really reach its effect. It does have the possibility for some side effects. And so there's some trade-offs there, but for many people it is a safe and effective option. It doesn't work for all prostate shapes and sizes. The prostate has to be big enough so that shrinking it will really work. So there are also other characteristics that may not be well suited to that medication. So that's the answer to that question. The other sort of first line options are the water vapor therapy, or the Rezum is a minimally invasive option. The UroLift is another minimally invasive option. And then we have the more invasive surgical procedures. Next steps, generally talk to your primary care physician or urologist. A lot of times, as I said, there can be some modifications on lifestyle, other diseases, medications that may be helpful for urinary symptoms, but sometimes then considering some of these other options. All right, so maybe we'll get to some questions.
Yes, absolutely. Thank you so much, Dr. Sulek. We have a couple questions coming in through the chat. Again, if you do have questions on the presentation, just type them into that chat function. The first question we have, why not just do a prostatectomy from the start?
So that's a great question. And it's a really good question because the prostate itself, after reproductive years, really does not serve a particularly important function. The problem is what's directly around the prostate. So directly around the prostate is the urinary sphincter that controls urination, and then also the nerves and blood vessels that go to the penis for erections. So for both urinary control and sexual function, the prostate is pretty important. I guess the real answer is that most people do not need their prostate removed, and it's a much more invasive operation that has more potential side effects. So we really try to reserve the radical prostatectomy for someone who has an aggressive prostate cancer that we're worried about potentially spreading and potentially causing death. So for everyone else, we'd really like to find a less invasive option that to really optimize quality of life.
Excellent. The next question we have here are, what are the primary dietary adjustments you can make?
So diet-wise, it's different for different people. Sometimes avoiding spicy food, acidic food, foods that are high in preservatives, all those things, smoked foods. Sometimes those things can be helpful. The really what the dietary modifications is getting at is avoiding caffeine, alcohol, those kinds of things. Tea, they're all those things are both bladder irritants and diuretics. Especially important oftentimes is in the evening. Reducing intake of all of those things can potentially help with these kinds of symptoms. As far as, is there a food that's high in, sort of plant derivative X that's going to shrink the prostate? Probably not really.
Okay. Can you talk through what retreatment rate means and why it would be higher on one minimally invasive therapy versus the other?
Sure. So retreatment rate means needing to do something else for the prostate. So either get back onto medications or go to another treatment option. So having another treatment done. So the potential reasons for that are numerous. Those two treatments that we were sort of first discussing, the Rezum, the steam treatment for the prostate, and the UroLift, they're very different treatments. The Rezum treatment involves actually removing, well, not removing, but destroying that prostate tissue with water vapor or steam, and then the body resorbs that tissue. Excuse me. So that procedure is great for the reason that it reduces the prostate size by 30 to 50%. The prostatic urethral lift or the UroLift procedure is very different. It is essentially using clips to tack back the tissue of the prostate. So for certain individuals, that probably will mean that the prostate will continue to grow in such a way that within the next 5 years, there may be a need for additional medication or additional treatment. That's really part of the reason why a sort of good individualized discussion with patients is important, because everybody's a little different as far as which option might be best suited to them. Because for one person, we might really be focused on reducing the risk of retreatment rate, whereas someone else might want to reduce the effect on the prostate, et cetera. So part of it also has to do probably with patient selection. I always like to do a small procedure, a bladder scope, prior to deciding on the ideal treatment option, because I believe there are certain prostate configurations that are better suited to one procedure or another.
Okay, we have a couple different questions around meds here, so I'm going to try and summarize them all into one. I will start with, if you're on Flomax to treat a neurogenic bladder from MS, would you recommend another drug since that does not treat the bladder?
So that's a great question. With multiple sclerosis, there can be several issues with urination. So unfortunately, the main problem with MS is that the nerves or the spinal cord that sort of transmit the message from the brain to the bladder can have lesions that prevent that transmission. And so unfortunately, there's no medication to get the bladder to squeeze more efficiently. People have tried some, but really they haven't worked very well. Now, there are some other medications, and that we could sort of go into more detail another time, but really the Flomax in that case is treating any additional BPH that may also be going on. It also may be working to relax the bladder neck, which may help with that particular issue, but that would be kind of a more specialized discussion.
So to clarify, there's no medicine that actually shrinks the prostate, correct?
The finasteride or dutasteride does shrink the prostate by about 30 to 50% over time.
Okay, excellent. There's a lot of questions here around TURP. Do you recommend continuing finasteride after a TURP procedure? What would make you choose a TURP procedure? And does the TURP procedure have a retreatment rate?
So those are all great questions. I think first, would I recommend continuing finasteride after a TURP or really any procedure? So it's a discussion I always have with patients. My personal philosophy is that one of I feel like my missions is to get people off medication if possible. And so for a lot of people, my thought is, okay, after a TURP or a laser prostatectomy, there is a chance that within about 10 years, the prostate will regrow to some degree. And some people really want to try to do everything to avoid that. So staying on the medication is reasonable for them. In general, I try to get people off all prostate medications after prostate surgery or procedures if possible. As far as who would I recommend a TURP for, I personally oftentimes will instead choose a laser procedure, the green light procedure to vaporize the prostate tissue. It's just a personal preference because there's a little bit less bleeding. I feel like I can treat just as much of the prostate tissue, and patients can generally go home the same day without a catheter rather than having to stay overnight. So that's just a little bit of a personal preference. The main individual that I recommend a surgical option for is number one, anybody who's suffered kidney failure or kidney damage due to BPH. Most people who are in urinary retention, and then occasionally somebody who really wants to treat maximally and minimize their chance of needing another procedure.
Great. And there's a lot of questions about retreatment. So if someone had Rezum or green light or even a TURP years ago, what are they eligible for if the prostate does grow back? And it could vary for any of those.
So one of the good things about any of these procedures, and not that obviously we want to minimize retreatment, but for either the Rezum procedure or the UroLift procedure, they do not sort of block the possibility of any of the other procedures in the future. So for example, today I had a patient who had been treated a number of years ago with Rezum, and he actually did have some recurrence of symptoms in the past 3 months. And so we sort of went through the workup and found that what he had was actually tissue regrowth in a very particular area. And so we were actually able to use that UroLift procedure to deobstruct the prostate from that area. So actually that was I think a very nice use of that option, because it was a focal obstruction from the prostate that we could just use a couple of those little tacks to open up that portion of the prostate. So hopefully he'll have a very good outcome from that, since he's now nice and wide open. But really the short answer is that hopefully retreatment rates are not super common, but when we need to do them, all options really are available depending on where the issue is.
Are side effects from finasteride reversible?
That's another very good question. Most studies show that yes, they are reversible. At this point, we have quite a lot of long-term data on. There's not only finasteride, but there's the hair loss medication Propecia. That's just a different dose of that same medication. There is one very concerning study where individuals had decreased sex drive, and it didn't really return after in that particular study. Rarely the breast tissue development is usually reversible, but every once in a while there's a case where someone with that issue needs additional intervention for that. So the answer is most of the time it is. The other kind of issue with it is that I always say that medication is slow acting, slow on and slow off. So it will take about 6 months to 3 to 6 months at least to for the body to completely clear the effects.
If you're in watchful waiting, why wouldn't you go straight to water vapor treatment before it gets worse?
That's a great question, and we have some new data looking at 50,000 individuals over not my personal series, but looking at individuals over time, and this is a progressive issue for many men. So I think the easy answer for that is that some men are at a point where really it's very mild, and for them I think sometimes they're just not ready, and that's okay. But I think for a lot of men in that situation, if they have a sort of a flow rate and bladder pressure that are that suggests that their bladders are starting to work harder, certainly at the very least further workup is indicated, because as you sort of go along the process, and it's a pretty predictable process, that given enough time, that frequency, urgency, kind of irritative symptoms will start turning into weaker stream, can potentially sort of start turning into irreversible issues with the bladder. And I think the short answer to that is that there are people who that process is very, very slow, and so they're able to kind of deal with it. It doesn't affect their lives very much. But I think if you're someone who's having significant issues, I think talking to your urologist and discussing options is very reasonable.
Have you seen any reduction in prostate size from a prostate biopsy used to screen for prostate cancer?
The short answer is no. A prostate biopsy takes very small tissue samples, and even in a small prostate, even with a lot of biopsies, it's not enough tissue to really change the size of the prostate. The one interesting thing that brings up is the area where prostate grows is generally along the outside rim of the prostate. So usually that tissue in the peripheral zone does not affect the urinary symptoms. It doesn't mean people can't have both a little bit of prostate cancer and some BPH, but that benign adenoma tissue that grows and obstructs the water channel is in the transition zone, where really it's fairly rare to have prostate cancer in that area. So really a prostate biopsy, outside of maybe a little edema of the prostate over the first couple of days, really should not affect urination in any way.
Does Cialis help with BPH?
It does, and that's something we didn't talk about here, but there's an interesting link between BPH and erectile function, and we are not really entirely sure why the tadalafil or Cialis, if used once daily, can be helpful for urination. So that is certainly an option to try. I don't think there are any studies really looking at sort of long-term bladder function and daily Cialis use, but certainly it can help with both issues.
I've had UroLift procedure in the past 3 years. Now doctors have me on doxycycline for blood pressure, starting to have BPH symptoms again. Is that reaction to the BP med?
No, I don't think it's a reaction to the doxazosin. The problem is that oftentimes the dose used for hypertension is not the same. Usually, if someone needs a medication like that and also has hypertension, usually we sort of choose different options because oftentimes it's not the best of the options for BPH kind of issues that are available. But no, I don't think that medication is causing the new symptoms.
For someone with renal disease, what's the best thing to do? Are lifestyle changes the focal point?
So it really depends on what the reason for the kidney disease is and how severe it is. Excuse me. There are people who have kidney injury from BPH, and in those individuals, I recommend a very aggressive, proactive approach. So if you have swelling of the kidneys and kidney injury from BPH, which we do see not infrequently, I recommend for that immediate deobstruction of the prostate, usually doing a TURP procedure or that green light laser procedure. Most of the time, if a patient is acceptable candidate for general anesthesia. If someone has some kidney disease that isn't associated with the BPH, then all of those options, the Rezum, UroLift, laser, all those options are available. Excuse me. A tricky situation is the patient with BPH and complete renal failure. So if that's kind of a more particular case, but we could discuss that on a individual basis.
How much of the prostate is removed during the UroLift procedure?
No prostate is removed during the UroLift procedure. So what the UroLift is it involves placing a series of implants or clips to remove the prostate tissue from the water channel. We sort of think of it like pulling back the curtains. So if there are curtains of BPH tissue growing into the water channel, it involves pulling them back. So that's both the kind of highlights the good and the bad of that procedure. On the good side, it's the only procedure that involves treatment of the obstruction from BPH without actually destroying prostate tissue. And oftentimes that decreases the recovery time. It means there's no effect on sexual function, and recovery time is generally relatively short. Now, the downside is that it doesn't remove any prostate tissue. So it's a little bit of a balance, and it depends on what the patient's issue is, what their goals are, and exactly what the best option is. I really end up doing about the same number of Rezums and UroLift. I think they both are excellent therapies, but I think that they both serve specific functions.
Can you explain a little bit more in depth the laser procedure?
The laser procedure, it's called photovaporization of the prostate. So I wish I could pull up a YouTube video is the best way to see it. But essentially, it's a general anesthesia procedure where we go into the urethra or water channel with a scope and then use a laser to vaporize the tissue of the prostate. So at the end of the procedure, the BPH adenoma tissue has been removed. And there's a clear open channel into the bladder. The positive is that it doesn't generally require a catheter afterwards. It does not require a hospital stay afterwards generally. And it usually results in fairly immediate improvement in the flow of urine. The downsides is there is removal and destruction of that prostate tissue, so that fossa has to heal. There can be some frequency, urgency, bleeding in the urine afterwards. And then also it does have a small risk of erectile function issues, although it's probably about 5% or less. And then it does oftentimes decrease the amount of ejaculate.
Excellent. Last couple questions here. Can you talk about the length of time it takes to do these procedures? I'm assuming minimally invasive.
So the Rezūm procedure, the STEAM procedure, I'll just quickly go through that one. It's a minimally invasive procedure done in the office setting. Essentially, come in. Most people do a Pronox or laughing gas that they breathe in. So that's a very quick on and off kind of sedation. We place some numbing medication into the bladder to anesthetize the bladder, and we do a block of the nerves going to the prostate. We next use a small scope to go into the water channel and use a treatment device to give several treatments of that steam or water vapor to treat the entirety of the BPH tissue. That procedure takes about 10 or 15 minutes in total. Afterwards, patients do need a catheter for a short period of time. You can drive yourself home. The laughing gas wears off very quickly. Usually the discomfort afterwards is fairly minimal. The prostate implants or the UroLift procedure, that one's similar. We do the same anesthetic and the same prostate block, and then go into the water channel and place the implants or clips. Again, that procedure takes about 10 to 15 minutes. The laser procedure really depends on the size of the prostate. That's a procedure done under general anesthesia, generally in the hospital setting. It takes anywhere from 30 minutes to, I've done some very, very large prostates that have taken up to 3 hours. But that's for an extremely large prostate that would not be a candidate for either the STEAM Rezūm procedure or the UroLift. The TURP procedure, it takes about the same. It can be as short as a half hour if it's a small prostate. It could take an hour and a half or more if it were a very large prostate.
Thank you. And the last question I have is, when do you recommend 5-alpha reduction inhibitors?
So the 5-alpha reductase inhibitors like the finasteride or dutasteride, I think that the ideal candidate is someone with moderate symptoms who maybe isn't a candidate for other procedures or general anesthesia. And we want to prevent those symptoms from getting worse, and we want to prevent the chance that they will require a hospitalization or require a catheter in the future. So I think that sometimes people with a lot of other medical issues who have some urinary issues, but they're not urgent, I think sometimes those people do very well on the finasteride. I don't typically end up starting a lot of people on that medication, and I think I always present it as an option because it certainly is an option. I think that the reason why, and I can't speak for them, but I think for the reason why most of my patients don't choose that option at this point is because there are really good other procedural options that with a fairly small procedure can avoid the need for a medication like that. So I present it to everyone. I think it certainly is an option, but I don't have a lot of people going that route at the end of the day. But there are certain people I certainly do recommend it for.
If you have post-gerbil blood spots in boxers, could this be coming from the prostate?
It certainly could. Any blood in the urine is something that definitely needs to be worked up by a urologist. There are a lot of different things that can be potential causes. But blood in the urine is something that certainly should be should be evaluated, because it can be from any number of things, and it's something that we would need to get to the bottom of. I think more broadly that brings up a question, and it's great that everybody came on and is interested in this. I think that we as men, I certainly think my wife would agree, like to avoid our medical issues and try to deal with them as long as possible. And I think a lot of times that isn't necessary, and there are better options. So certainly something like that. But even the frequency, urgency, getting up at night, slow stream, I think those are all things that a lot of people can benefit from getting some treatment for those.
Excellent. And that was actually the last question. So I think you you kind of had some closing comments there, but I will allow you to take over. Thank you all so much for coming. Dr. Sulek, close it out however you see fit.
Wonderful. Well, thank you all for coming. I really appreciate it. It's been a lot of fun to talk about some of what we do. And if anybody has further questions, we would love to discuss more. So there's information on the website about getting an appointment. And really, I'm sort of the mouthpiece today, but we have a lot of good providers and who can help with a lot of these issues. So I think just if it's something that's bothering you or someone you know, seeing a urologist and just at least talking about what options are out there